Okay.
All of the above.
Okay, so this is a good one for Boudreaux. So do liver tumors have legs? We often will say roots, but legs, or what they call that go deep into the liver, or is it just on the surface? So I think it's sort of like, what is the pattern of growth of neuroendocrine tumors in the liver?
Yes.
How do we determine that and deal with it in the operating room?
So these tumors can be anywhere. Sometimes they're on the surface, sometimes they're deep, sometimes they're both. This is zebra, man. Everybody's different. We don't know what is the driver of why some tumors have a predilection to just be on the surface and you can pluck them out like grapes. Other times they're really deep in the liver and you have to do a really whole lot of gymnastics to get to them and get them out of the liver and still have a good liver when you're done. And so whether a tumor is resectable or not is a lot like location, location, location. And the location in the small tumors deep in the liver typically are not worth chasing. You're better, if you can target them with ultrasound, you can intraoperatively ablate them with, ablative device du jour, whether it's irreversible electroporation, or it's thermal ablation, microwave ablation, or whatever, but you don't destroy a lot of liver getting down deep to that little thing, but you can still kill it if you can image it. Larger tumors that are deep in the liver, if they're really tightly bound to some significant critical structures in the liver like blood vessels and bile ducts that we can't pry them loose from, we don't want to sacrifice those critical structures and then hurt the good liver that they're feeding. And so now, for those types of tumors, we may have another out where we can partially ablate them. It may also be that we will be able to use histotripsy to then sort of paint those lesions. The neat thing about histotripsy, once you target it in X, Y, and Z axis, and you tell the machine where it is, the machine takes over, and a robotically controlled arm moves up and down, and you just watch the thing moving, doing its thing, and vibrating to death these tumor cells till they're just all turned to liquid jelly. It's a really cool thing, and there's no symptoms post-treatment, no pain, no nothing. Patients wake up and say, well, did you do anything? They just had a real good nap, because you have to be under anesthesia because you got to be real still. Can't wiggle. So in general, neuroendocrine tumors tend to be sort of what we call, what's called a pseudocapsule. They're pretty well contained, so you don't need to be a big margin and sacrifice a lot of good liver around them, whereas other types of tumors that are spread to the liver, like colon cancer, if you don't get a margin, that tumor's coming back with a vengeance pretty quick. So it's a different animal in terms of what you can, the rules that you can get away with in neuroendocrine tumors don't apply to what you can or cannot do for other types of more aggressive cancers in the liver, like colon cancer and stuff like that. So it's just a different animal, and that's, if anything I've learned over the years of doing this is that everybody's different. That's the main thing, and you just have to sort of be able to kind of adapt your plan in the operating room. Sometimes you go in there with plan A and you end up in plan B, C, or D. Our imaging that we think is perfect isn't perfect. It says stuff should be right here, and you think it's not there, it's over there, or instead of 2 tumors, there's 10. So stuff like that. Sorry, it's a long answer for a short one.
Excellent. Okay, I'm going to ask a question on behalf of the audience to Dr. Harris. So in Europe, the radioligand therapy is like, it looks like they have an entire wardrobe of options. And it's almost like fairy dust. They're like, take a little bit of this and a little bit of that. And so they have yttrium-90 and they have lutetium and they have this. And I think that even for people outside of radiation, the field of radiation, we really don't understand. Like if someone would say, am I a better candidate for maybe a lead, whatever, which is alpha, versus an actinium, which is alpha, or a Y90, which is blah, 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 or a lutetium, is how would we know what would be more or less appropriate, especially if you're looking at it in the context of a clinical trial? Was that a hard enough question for you, Kendra?
Well, it's certainly true that Northern Europe and Australia have got us beat 8 ways till Sunday when it comes to how much experience there is with radiopharmaceutical deployment. And I think that's due to a variety of complicated factors. With respect to the specific question that you asked, there is not one answer, because I showed you those beautiful diagrams, or I think they're beautiful, of one element becoming another element. And that's part of it, right? Which is what is the specific flavor of radiotherapy. But the other part of it is that the question of what is helping to target that molecule to the right location, how tightly that targeting attaches, how long it occupies that space, how easily that molecule is able to diffuse into or not tumors that are larger or smaller, is something that is not just going to vary between tumor types, it's also likely to vary between people who have the same tumors type. And so, in general, this is something that actually we've faced a fair amount, again, in prostate cancer, because we have like 5 or 6 different ways of targeting, and clinical trials with 4 or 5 or 6 different radioactive particles. And generally what you do is you pick the thing that seems to work the best first and has the fewest risks. And I think with respect to the question of alphas and betas, when I put the 2 lists of characteristics up, one might be misled to think that I love alphas and think that they're so much better, but in fact, what is a strength is also a vulnerability. That is, particles which cause more cancer tumor cell death have the capacity to do more harm. Having a shorter distance of effectiveness is good in that you might worry slightly less about adjacent damage, but it then depends on the ability to deliver that particular molecule close enough to every cell you want to get to. And so it is not an easy thing to navigate during an early time point when really we're going from one well-characterized ligand particle combination to now maybe having 2 clinical trial options. And it's a reason that the lead trials are trying to accommodate this idea of being treated after receiving Lutathera. But I'm afraid it's not something that has a straight answer.
No, that's a good answer. I think
Oh,
that.
oh,
Go
sorry,
ahead.
go ahead.
No, you're the one answering the question.
No, I was just going to make one other quick comment about an analogy for SBRT that you can use. So she talked about that focused external radiation. The analogy I use for that is if you're out in the woods with a Girl Scout troop and you've given them all a flashlight, 1 flashlight each, and you say, hey girls, I want to see the tree, but it's nighttime. So what might you do? You might line the Girl Scouts up around the tree, and then they would all turn their flashlights on and point it at the tree. And where all those beams intersect might be quite bright, whereas each individual flashlight would be quite dim. And that is the way you get a high dose of radiation to one area while sparing the rest of the liver. That was just an aside.
And what's the Girl Scouts?
That's kind of also how the ultrasound thing works. no one ultrasound beam does anything, but it's an array where they all point together like the Death Star, and they all intersect. That's where your intense energy delivery
Girl
is.
Scouts, Death Star.
But you get a brighter light and a more intensive stuff if you shine them all in the same spot. My feeling on Lutathera versus, say, lead, I think, I don't have, it's not science, but I think there may be a little more side effect profile to lead than Lutathera.
Oh, I think there's definitely.
You know, in terms of, so maybe older, more frail patients may not be the best candidate for Lutathera, but I mean for lead, but they may be a better candidate for Lutathera. The thing we don't know is if you've already had Lutathera, how much is going to be too much, you know, and how much is enough? Can you do both? And so that's the trial that's going on now. People that have had beta therapy already and now are coming around for alpha therapy. We think it's going to be a good idea and it's going to be okay, and the results are certainly promising, but what we don't know is what's the downstream effect 5 years from now? Don't know yet of that sort of thing. So more to, you are the people we are going to learn from about how, I'm serious, we are going to learn by doing this and by people stepping up and saying, yes, I want to be in a clinical trial, and you know, let's learn some science while trying to help some patients. So thank you for that.
Okay, so back to you, Boudreaux. You had talked about some of the consequences of having to take the ileocecal valve when we have to take it, and I think he mentioned that is less well tolerated in patients with neuroendocrine tumors than it is if we were to do the exact same operation for like a colon cancer in that part of the colon. So the question is there anyone working on a technique that would rebuild the ileocecal valve?
Well, I was talking to someone earlier about that. The pediatric surgeons have a particular challenge with premature babies in that they get a condition called necrotizing enterocolitis. It means their intestines die, and they have to have it removed because it's gangrenous, and so they're condemned to either short bowel with a little bit of gut left and diarrhea all the time and not enough to nourish themselves, so they're on intravenous nutrition, or you have to slow that transit down. And so what they're doing are kind of artificially reconstructing an ileocecal valve with a piece of intestine, and that work has kind of been ongoing for quite a number of years, so obviously it hasn't been perfected yet, or we'd all be doing it. But it's still a very big focus, and probably the people who are going to figure it out first are going to be the pediatric surgeons, I think.
Yeah, good answer. Okay, and then so back to Kendra. It says, so this is particular for the lung, and so the treatments that would perhaps be less relevant to the intestine but are relevant to the lung, the question is, are there any new treatments for tumors in the lungs that have sort of evolved over the last few years?
Yeah, actually, I don't know what's happening in Indiana, but there was a guy in Indiana in the early 2000s named Bob Timmerman who actually, in the context of primary lung cancers, was very frustrated with how poorly we did when we tried to treat them with standard radiation. And he pioneered the technique, actually, that was talked about as being deployed in the liver, called SBRT, the stereotactic body radiotherapy, which just is basically the idea of giving quite a lot of radiation in a very few number of days using external beam radiation, more standard radiation. And that approach of being able to give a lot more radiation and focusing it just on tumors was first established as being a good approach in the lung, and is able to be used and directed against any tumors that are embedded within an organ that has subunits that are working alongside one another. So like the liver has lots of subunits working alongside, so if you take out a tumor and a tiny amount of surrounding area with radiotherapy, the remaining liver is fine. Same thing with the lung. You can have a tumor in the lung, and take out a small rim of surrounding lung with the radiotherapy, and the adjacent lung can function. And so that is a technique that I deploy increasingly as data emerges in a lot of different settings that it makes sense to control high-risk cancer spots in their various locations. Now, in the liver, what I would say is that for the most part, doing that is generally something that's like one of the latter things that is done. It's deployed for tough spots. It's deployed for recurrences that are hard to manage. And part of that is what Dr. Maluccio said about when you give radiation to a spot in the liver, you don't get this beautiful, easy to interpret change that can be seen. And it complicates your ability to understand the effectiveness of the treatment in the relative short term. In the lung, it is a treatment that we use more frequently and earlier, just because it is an organ that's harder to burn or freeze or shake for a variety of reasons. And so, yeah.
Great. Okay, so there's one on biomarker testing for you, Boudreaux. Historically, this group, along with the IA group, have probably been the strongest proponents of biomarker, the surveillance in patients with neuroendocrine. For this question, particularly says neurokinin A and chromogranin, but why don't we just talk about the relevance of biomarkers when it comes to neuroendocrine, when they're most valuable? Sure.
So there are the biomarkers that are like active hormones we can measure to see how things are going and what's happening. But in terms of the biomarkers that Mary's referring to, is there sometimes these tumors make little molecules we can pick up in the blood that don't necessarily have any noticeable biologic function or don't produce an effect anywhere in the body, but it's stuff we can measure. And if it's something the tumor makes that we can measure, it could be a serum magnolia level for all we care, if it's making a lot of it. And then we do an intervention and it falls down to a very low level and stays low, we say, well, whatever we're doing is working. And if it starts rising again, we say, maybe something's going on. It's time to get a scan or something. So it's like a poor man's CAT scan. You could just do some blood work every 3 to 6 months instead of a scan every 3 months, as long as things are copacetic. The problem with chromogranin A, which was kind of one of the first markers we had, back in the 70s, to look at identify neuroendocrine tumors, is that about 40 different things can elevate a chromogranin A, includes most of the medications that people are taking. How many in this room are taking Pepsid, Protonix, Acifex, the purple pill, omeprazole, or any of those kind of drugs? Guess what? That'll change your chromogranin A level. So half the population of the planet is on one of those drugs because it makes them feel better. It makes you, for acid reflux and indigestion and all that stuff. So kidney dysfunction can affect it. Liver dysfunction can affect it. It's a bunch of drugs, so we don't rely on it. Although if that's the only thing that's elevated and that's what we have to go by, that's what we measure. Neurokinin A, it's a kind of a weird one. It doesn't correlate with tumor burden like some of the other markers do. We think they do at least. But it is a prognostic indicator. And what we've learned by studying patients on two sides of the Atlantic Ocean now is that people that have neurokinin A levels greater than 50 that we cannot reduce and lower by any means are not going to live as long as people whose neurokinin A levels are less than 50. It's a prognostic indicator. Dr. Woltering used to say, if your neurokinin A level is less than 50, you're going to live forever. If it's over 50, then you have about a 50-50 chance of being alive in 3 years. The interesting thing is, though, people that had very high neurokinin A levels at the beginning, and we do an intervention and it goes down to a low level, act just like the people that never been high in the first place, and they have a good long-term outcome. Probably the one we use a lot of, it's hard to measure and it's pricey, is pancreastatin, because doesn't seem to be as affected by other influences like drugs and other conditions. And so we think that one probably does correlate with tumor burden, and so that's probably one of the ones we tend to look at. And then whatever biologic compound that may be active, like serotonin or insulin or glucagon, whatever the tumor makes. If it's something we can measure, we want to. So we do usually a big battery of tests to see if we can pick up something to see what does that person's tumor make, and if your tumor makes compound X, that's probably the one we're going to look at the hardest. So that's another one. Everybody's different.
And if you've wondered who the people are out in the hallway that have helped sponsor this event, so one of them, the Inner Science Institute,
People who made your hats.
is probably the oldest and only neuroendocrine specific lab in the whole country. It was the dad who started it was a NASA physicist who ultimately then went into neuroendocrine, and it was really the history of this program and Dr. Woltering that seemed to come up with the relevance of a lot of those biomarkers. So if you're wondering, you can talk to them. Inter Science Institute. Okay, back on something, because I realized that Kristen did the pancreas talk, but can you explain how a compromised pancreas or some of the patients with a pancreatic neuroendocrine may struggle with elevated A1C levels?
So, in general, when we think about the pancreas and insulin production, if you have a normal pancreas that can make normal amounts of insulin, you could just about remove about 80% of a person's pancreas and they not become diabetic if nothing else is going on. Like they have a good diet and they're not overweight and stuff like that. But that eliminates probably 75% of the people in this country. We're just face it, we're not as thin as we used to be. But so the pancreas has to work harder to make more insulin. So when you lose pancreas from, say, a surgical procedure, if you're on the border of having enough insulin to be normal glycemic and now you lose a big chunk of functional pancreas, then likelihood of having abnormal glucose testing and having abnormal hemoglobin A1Cs and maybe having need for diabetic medications, the risk of that is going to increase, which is one of the reasons why we try and take the least amount of pancreas we need to take. Sometimes we'll just enucleate the tumor out of the pancreas and leave the rest of it behind when it's appropriate to do so. So the idea is parenchymal sparing surgery whenever you can. You don't want to take out the good stuff with the bad if you don't have to. But there's once you've lost islet cell mass, it's not like the liver. You don't regenerate and make new islets. That's how many you get. So you have to be good to your pancreas.
Cool. I will answer the last three questions because they're all about histotripsy. And this is one of those where we're super excited. It's kind of like anything where you say, oh, before we're like, ooh, we're all alpha, even though the surgeons are totally alpha. Histotripsy. There have only been 100 cases in the entire U.S. done, and they have been done by probably 10 different practitioners in a whole slew of different types of patients. So what makes a good or bad candidate for histotripsy is you have to be able to see it on ultrasound, so that people that are interested in that technique need to come in and we need to get an ultrasound on that machine, because that's what dictates the angle that we have to get that virtual reality head in order to position to lock it in like the car wash. Now they are rapidly developing much better heads that are a little bit less cumbersome, a little bit more nimble. So my thought is that it'll only get better, but for the most part, the liver is sectioned into a bunch of different segments. 2, 3, 4, and 5 are all usually within an acoustic window. In a super thin person, we can probably get to 1. We have a couple people on the schedule for that. That's the one that's sitting way in the back, but that we're limited by a 12 centimeter depth. And a lot of people within Louisiana have a greater than 12 centimeter depth, because you're surprised that that's actually not that deep. So it's really the acoustic window and our ability to do it. They don't have a probe that will go through the rib cage, and so things that are way high up on the right are very difficult, but great for SBRT. Insurance coverage is always a bit of a challenging answer. So the way that things get into medical policy is based on codes. The codes have been established. They have been approved through CMS. We call that a charge master. Approved through CMS, but that oftentimes the medical policy of individual insurance companies takes a little while to evolve. So our prediction is that we have to do some uber documentation of why we think this is the appropriate technique in that particular case. We'll probably have to do some peer-to-peers, but if you were to talk about cost of each of these, the ablative techniques are all going to come out at just about the same cost, so I don't believe that we feel like we're going to have huge barriers in insurance coverage. And then the trials in immunotherapy in combination with histotripsy is that those have not been done, but obviously generating a lot of interest since we have immune modulator systemic therapies. But if you were to extrapolate like something from melanoma or renal cell, the way that those used to be treated when we were just learning about immune therapy is you would be taking out these identifiers, these antigens. You'd be taking them out of the person. You'd be taking them back to the lab and like reproducing them like an army in your lab in a petri dish. And then you'd be injecting them back into the patient and using the most primitive techniques of jacking up the immune system. And it made people literally almost like on fire. Like it had to be in an ICU, and it was only done at the NIH. And so we've come a long way from just doing those primitive, like let's just find the identifiers and then jack up the immune response. Because in dark-skinned individuals, like with melanoma, they got like vitiligo spots. It was so powerful an immune response that it literally took chunks of their like normal melanocytes. They also got an awesome response to treatment, but that it was just a little bit more than what's going to be reasonable. Now that we have immune modulator therapy, sure, you have the opportunity to use some of the ways that we are manipulating the immune system in ways that we want it, but under no uncertain circumstances are we even close to doing that until you have it of proven benefit in a certain tumor subtype, and I think that'll probably take around at least a year. But there's a lot of discussion on that. Okay, and that's it. Does anyone have anything? We got 3 minutes and 53 seconds.
Oh, just one other little thing about histotripsy. There is, sometimes we are lucky enough to have an end around, even though the tumor may not be imageable on ultrasound very well, which is sometimes because people have had previous liver-directed therapy. It just alters the image to the ultrasound. The sound waves just don't tell it. They can't tell the difference between tumor and normal liver sometimes. If you can image the tumor on cross-sectional imaging like MRI or CT scan, there's now a way the software can fuse the ultrasound. If there are identifiable landmarks within the liver, certain structures that say, okay, this tumor is exactly 2 millimeters away from this tumor is exactly so far away from this structure in this direction, this dimension, you can then tell it, go to that spot, and it fuses the ultrasound with the scan, and using GPS and a robotically controlled arm, it goes there and targets that area that you tell it to go to. So more to follow on that. This is a whole other, for all this to happen, you had to think about what had to happen. We had to figure out, well, that if you put more than one ultrasonic beam on something in an array and a bunch of things, you'll get something. You had to figure out what was the frequency and the wavelength that had to be to get the effect you wanted. You had to have a good enough ultrasound to see the thing. You had to have a robotically controlled arm that is so precise that it's within fractions of a millimeter of targeting where you want it to go and no place else, and all the software involved to tell it to do those things, and the GPS positioning system, and also all these things that are coming from a whole bunch of different places came together to create this new therapy. And so it's a pretty exciting time to be around right now, because we have access to things now that we didn't have, heck, we didn't have 2 years ago, much less 5 years or 10 years ago. So it used to be about every 10 years we came out with something new in neuroendocrine tumors. Then it was about every 5 years. Then it was about every 2 years. Now it's almost every year to year and a half. Some new thing is happening, and that you're going to be able to take advantage of going forward. We just got to keep you around for the next new thing. That's our goal.
And then I did miss one more but it is relevant. What is our group expecting of AI, other than the old timers are like, oh my God, that's like totally
Don't play chess with it.
freaky, like totally freaky.
You'll lose.
But yeah, Kristen Limbach wrote an entire grant on the use of it. So in medical arenas, we call it machine learning, which is really just AI. So she wrote an entire grant on the use of AI or machine learning algorithms, predominantly in pancreatic neuroendocrine. That's because the pancreatic neuroendocrines are a little bit all over the place. And so your ability to define what the drivers are of a particular outcome. And so apparently we have a machine learning division of expertise, which is awesome. And so I think that our database of over 7,000 of you patients and how you've done over the years with different diagnoses, I think that if anyone's going to figure out the role of machine learning in predicting how neuroendocrine patients are going to do, it's probably going to be our group and the younger generation, because that's kind of her passion project. Okay, and once again, 17 seconds to go. Thank you so much to the speakers, to all of you for being so patient, to the Waymans.